Hydration and IV Therapy, Part 1, Introduction to Nursing Concepts, Martha Olson from Iowa Lakes Community College. Potter and Perry, Chapter 31 and 41. Our principles of fluid balance are looking at regulation. Nurses can collect intake and output without a physician's order. We can also get a daily weight without a physician's order because we need to know, is this person maintaining regular fluid balance? Many times as we give diuretics, as we do other treatments to try to regulate the balance, either they're behind and dehydrated or we're taking fluid off because they have edema and congestive heart failure. We need to know, are the treatments, are the interventions we're doing or meds we're giving, are they assisting and working like we want? We know the kidney is one of the main regulating organs, but we also know that the liver, the lungs, all of the organs work together to maintain homeostasis within the body. Water is that single largest component in the body at about 60% of an average adult. It's much more in an infant and young child and less in the older adult. That healthy, well-oriented adult is capable of maintaining normal fluid, electrolyte, and acid-base balance because of the adaptive mechanisms that the body has. It either opens the floodgates and lets more urine out if it needs to. You can maintain your hydration status by the thirst mechanism. Intake and output, distribution throughout the body is looking at, is the water that we have inside the cell, is it interstitial, is it intravascular? And all of that then is regulated by the body, looking at both our electrolytes and our organ and how the organs work. Our thirst is stimulated by the blood getting thick. You don't drink enough, your lips get dry, your urine output gets more concentrated, and as that plasma osmolarity increases, then the osmoreceptors stimulate the hypothalamus to tell you you're thirsty. Hopefully the person is able to identify that and do something about that. Many of our older people are less responsive to the thirst mechanism, and if you work in long-term care, you know that many of your older people have to be encouraged to drink. They just don't feel thirsty, they get dehydrated, and then we see the trickle-down effect of urinary tract infections, confusion, orthostatic hypotension as a result of hypovolemia for them. Other things that regulate the fluid balance is that antidiuretic hormone. It's stored in the posterior pituitary gland and it's released when the changes in the blood osmolarity are identified. That prevents diuresis. It causes the body to save water. And if you have taken some pharmacology and you think about Lasix, Lasix is a diuretic. It works just the opposite as this hormone called antidiuretic hormone. Our aldosterone then is made on the top of the kidney in the adrenal, and it is released in response to the increased plasma potassium. That leads to sodium and water retention. That leads to weight gain, edema, and sometimes that can be good if you're really dehydrated or not. So when we have the antidiuretic hormone and the aldosterone working together, they help regulate the volume of fluid that you have in your body. The enzymes related are renin, and this is in Potter and Perry on page 887. Renin is made in the kidneys. It's an enzyme that's made in the specialized cells in the kidneys. Releases renin, and it has to decrease the renal perfusion secondary to the decrease in the extracellular volume. That in turn then stimulates angiotensin, which is an inactive form made in the liver. Angiotensin 1 almost immediately then becomes angiotensin 2, and angiotensin 2 causes vasoconstriction of the blood vessels, and it relocates and increases the blood flow to the kidney, trying to improve renal perfusion. In addition to angiotensin 2, it stimulates the release of aldosterone. As you think about pharmacology and how we give antihypertensives, the ACE inhibitors work on taking angiotensin 1 and not letting angiotensin 2 happen quite as well, because if angiotensin 2 vasoconstricts, when we decrease that, the blood vessels vasodilate, it lowers your blood pressure, and that's how our ACE inhibitors work on this enzyme that we have in the body. We know that fluid balance is affected by age. Again, your newborns have a lot more water and they are much more vulnerable to fluid volume deficit. I can be home for 3 days with diarrhea and probably be okay. That newborn cannot tolerate it that long and they need to come in much earlier. So when you're a clinic nurse and the mom calls and says the baby's had diarrhea, you probably need to see the baby, especially if it's a very young one. Are they able to keep fluids down? And how many wet diapers have they had are a couple of questions that you need to be asking. As we look at older adults, we know that because they don't have as much adipose tissue or less muscle mass, that also has an effect on their fluid balance. Females tend to have more adipose tissue than males, and we know that obese people have less fluid body weight as a result of the adipose tissue they have. Where we see our blood pressure is what we call the intravascular. Intravascular is inside the vessel, and that regulates where your blood pressure is. Now, if I don't eat protein, I'm older, I am albumin deficient. Albumin is that protein that helps keep the fluid in the right compartment or in the right space. That nice intravascular fluid then can leak or seep into the interstitial space, and that person will actually have edema because that interstitial is kind of that in-between space that causes you to be puffy. It doesn't help support the blood pressure because that is only in the intravascular space. Intracellular is about 40% of your body weight. Extracellular is about 20% of your body weight. So we can see this is a big part of, the total body weight distribution. Interstitial is between the cells, and again, intravascular is your blood volume. How it moves is through diffusion and osmosis, talked about on page 884. We know diffusion, it's the process in which the solute or gas or substance in a solution moves from an area of greater concentration to lower concentration. The example they give is, when your creamer distributes evenly in the coffee. We also know that osmosis then is the movement of water across that semi-permeable membrane, and that happens as a result of a pressure gradient. Boiling in the hot dog, when the skin of that splits open because too much water has been brought into the hot dog. Our normal body fluid needs are listed here. We need about 2,500 milliliters, more if you're an athlete working out several times a day with a lot of sweat, more if you're a firefighter and you're out fighting fires and doing that. I remember the fluids that they said the men that went over and were capping the oil wells that were blowing up was phenomenal, like 4 gallons a day or something like that. So we have to base it off of a lot of things, not just one thing, but as the normal person, we need about 2,500 cc's of fluid a day. Our fluid loss, we measure what we can, and any urine, diarrhea, anything coming out of Jackson Pratt or any of your drains, it can be measured, and vomit are all measured. Things we can't measure, they're called insensible. That's through breathing, through your skin. And then if you would open up my abdomen and have it open for several hours doing surgery, I would have a lot of body fluid loss through an open wound, or maybe I have decubiti wounds that are open as well. So the average adult usually has intake and output that is equal. However, when we have patients in the hospital, there are many times where that is not equal. When you give me a diuretic and my urine output is much greater than my intake for the day, you would expect weight loss, you would expect less edema. If I come in dehydrated and you give me IVs and you're running them at 250 an hour, you would expect that my intake would be much greater than my output, because if I'm still dehydrated, my body's going to hold on to all that IV fluid that you're pumping into me. As a nurse, we can get intake and output without a physician's order. We can also get a daily weight without a doctor's order. Our key points to remember: you have to have at least 30 mils of urine every hour. That's for an adult. It's going to be very different for a pediatric patient, but that's a golden number to remember, because without 30 mils of urine every hour, I'm concerned. What is my blood pressure? Because remember, 25% of your blood comes off of that aorta into the kidneys to spin the nephrons to be able to make urine. with a low blood pressure. This is my patient that's been in the intensive care unit, and they come back with a lot of blood loss. Their blood pressure is very lower. They're hypovolemic and hypotensive. If I'm not getting 30 mils of urine out every hour, I'm calling the surgeon, and typically what they recommend or they will order is a fluid challenge. Run in some fluids over the next hour fairly quickly. And as we think about what size of IV we have in, if I have a 22 or 24 size IV, I can't do that. I need to start a larger, like an 18 or 16 gauge IV to run a fluid challenge in. For those not on hourly outputs, we would be looking at least every hour or every 8 hours, every shift. What is the color of the urine? What is the skin tinting, the mucous membranes? All of that comes together to help us. In the book, it talks quite extensively about the daily weight and how that really is a best indicator for us, because intake and output is very inaccurate. Insensible losses, ways that we can't measure. Patients that have fluid that is affected, your confused patient may not even think about being thirsty or realize they're thirsty, or your Alzheimer's patient that doesn't drink at all. Somebody that's depressed may be disinterested in meeting their fluid needs. With our aging, they may not want to be interrupted with their church or their card games to, have to go to the bathroom, so they just don't drink, or they kind of get behind with their fluids so that they're not interrupting social events for that. Our diuretic use, we know that after giving a diuretic IV, it should start kicking in and putting more urine out within 15 to 20 minutes. If it's a PO Lasix diuretic, we know it may take up to an hour for that to work. Other physical disorders we may see: pituitary tumors, hypersecretion of anti-diuretic hormones. So again, those endocrine disorders can come in to affect fluid when they are off. Congestive heart failure. Anybody with renal disease has the potential for having their fluid balance affected. Our renal disorders involve kidney function, so if there's chronic problems there, we know that the kidney is responsible for helping to control the fluid intake and output. And then any of our cardiac problems, because the fluids are allowed to accumulate when we don't have a strong pump pushing that through the body. Cardiac and respiratory work very closely together, and cardiac and renal also work very closely together, because without good blood pressure, we can't send that blood pressure down to the kidneys for them to do their job. And lastly, we look then at our assessment criteria. When the patient talks about being dizzy, I would get an orthostatic blood pressure. I would listen to that heart for 1 full minute to see what the apical sounds like if they are complaining of heart palpitations. Ask about what types of fluids and foods they typically eat. Are they on a fluid restriction? Are they on a sodium restricted diet? And then our assessment includes things such as age. That's a big consideration, because as I said, our young children often have a hard time maintaining their fluid and electrolytes and their hydration status when they have diarrhea and vomiting. Skin turgor is not a good assessment for the elderly, because their skin tends to tint even though they are well hydrated. Medications that they're on, the antihypertensives, the ACE inhibitors, the diuretics, many of our medications, even food has a diuretic effect. Your coffees, your teas, your colas. Their lifestyle can also be a factor. Are they drinking enough fluids? Maybe they're drinking only Diet Coke every day and not getting any water. And then past medical history always has to be a consideration as we think about, have they had kidney failure in the past? Are they on dialysis? Maybe they got a kidney transplant at some time. So many criteria and many things that we think of as we start this first part of our hydration unit. I would spend time in Potter and Perry looking at the page that talks about fluid volume deficit and fluid volume excess. What will you see on that patient? What will the blood pressure do if they're fluid volume deficit? What will the blood pressure be if they're fluid volume excess? The skin, the urine, all of those assessment skills in Potter and Perry need to be looked at, because that's the types of things that nurses need to be looking at with our assessment. This ends part 1.